Good afternoon, everyone. iTech welcomes all the participants for today's National Distance Learning Seminar Series. Today's topic is drug-resistant TB, basics of DR-TB and DST, and speaker is Dr. Anwar Parvez. Dr. Anwar is a public health specialist and is presently working with iTech India as Director Clinical Programs, where he is working in close coordination with NACO in providing national and regional level technical assistance for the HIV care support and treatment program. He also works as a clinical instructor for the Department of Global Health, University of Washington in Seattle, US. He is a national level trainer and is also a member of various guidelines writing group of NACO. His major areas of interest include training, curriculum development, HIV/AIDS, and tuberculosis program management and public health intervention programs. We welcome you, sir, for today's NDLS session. I would request Dr. Anwar now to kindly take over the session.
Thank you, Divya. Good afternoon, everyone, and welcome to this session again. So, as the name or title suggests, this is the first session or part 1 of this session on drug-resistant TB and basics of DR-TB and DST. Part 2 will be planned after some time, and that will focus on the treatment. So, basically, in this presentation, we will not be discussing the treatment part. So we will be talking about basics of drug resistance TB, and in which the definitions also will be addressed, or some of the definitions will focus on, and then some basics about DR drug resistance and how drug resistance happens, and then how it is diagnosed and what are the guidelines around it. So we'll focus on that part in this 1 hour. So this 1 hour we will focus on these will be the main focus areas, where we will talk about magnitude of drug resistance, a brief about the epidemiology in India basically, then causes of drug resistance, and then what are the definitions, as I said before, and there are certain tests, and we will try to discuss few tests which are commonly being used in the program or in the program setting, and what are the recent guidelines for programmatic management of DR-TB, which is called as PMDT in short, in the RNTCP program. As most of the participants for this webinar are from the ART centers, so we all know that we started treating TB in our own ART centers since 2016. So before that, all TB patients used to be referred to RNTCP for diagnosis and treatment both. But from 2016 onwards, we started treating these patients within our own ART centers. And whenever we come across any, and simultaneously we started doing CBNAAT for all diagnosis of TB in our patients. So whenever we diagnose any rifampicin resistance, our guidelines say that we should refer the patient to the DR-TB center. When we say DR-TB center, and as the patient who is a PLHIV, and who is coming back to us every month. So even though we are not directly involved in the management of DR-TB, but I think we should know what happens there in RNTCP under DR-TB management, because as the patient comes back to you or the ART center for counseling and for ART and for the regular follow-ups, it is important that we cannot close our eyes on what is happening if the person is diagnosed as drug-resistant TB case. So because there are so many interactions and so many issues with which a person will be dealing with, it is utmost important for us in the ART centers at least, to know at least that what is happening in the DR-TB center, or what are the RNTCP guidelines for DR-TB. So that is the intention of having this session here today. And as I said, in the part 2, we'll be focusing on the treatment part of DR-TB. So let's start with the first slide on the brief epidemiology. These are the numbers taken from the global TB report, which is available on the web. These are the recent numbers of 2018, and this has been published by WHO. So if you look at the picture on the left side also, these are all TB cases and untreated TB and undiagnosed TB. And out of this undiagnosed TB, again the magnitude of MDR and XDR. We'll go to the definitions of all these terms later in the presentation, but if you see these facts or numbers of DR-TB, there are 10 million cases which are happening of TB every per year. 3.6 million cases, that is 36 lakhs patients, never get diagnosed and treated, and 1.6 million are death. And this is the most common, again, death among HIV. And in drug resistance, if we look at the number, 5,58,000 rifampicin resistant cases, and 25% are again are recognized as drug resistance case. So rest of the cases we are either not able to diagnose them, or they die without our information. So the problem is not small. So it has again implications in the overall management of TB in any country, in fact. So in India, what has happened is there was a national drug resistance survey to know that what is the magnitude of this drug resistance, and how much do we have in this country in various groups, or what kind of resistance we have. So there is a report, again it is available on the web, from 2014 to 2016, and this is the National Drug Resistance Survey and DST pattern, drug susceptibility pattern of our patients. So this survey was done in 4,958, that is close to 5,000 patients, and DST results were seen for these patients, that what was the again drug susceptibility pattern of these 5,000 patients. So 72% patients of these were showing susceptibility to all drugs, all anti-TB drugs, and 28% showed resistance to any one drug, and there were 6%, above 6% MDR-TB, almost 3.5% or 3.6% cases of MDR plus any second line injectable drug resistance. We all know the definition of MDR, just I'm repeating here, which I'll again discuss later in the presentation, that if there is resistance to at least INH and rifampicin, it is called as MDR-TB. And there are second line injectable anti-TB drugs like kanamycin, capreomycin, amikacin. So if there is resistance to at least INH and rifampicin plus any second line, so these are like 3.6% of cases. MDR plus fluoroquinolone resistance like ofloxacin or moxifloxacin resistance, so those are 20% almost cases. And XDR, that is resistance to all MDR plus again resistance to the other drugs, it is XDR, that is around 1%. So what we understand by this, and this is the distribution based on the newly and previously treated cases. What we understand from this is, so out of all our TB cases in this country, we have like 72% cases which are sensitive to all TB drugs, which is the good news. But the bad news is we still have patients who are, which is not again a small percentage, we have still patients who are having drug resistance. Even though the percentage of MDR-TB as diagnosis, it's not exponentially high, but still we have like 6% of MDR-TB cases in our country. So let's look at some of the basics of or basic principles of combined therapy. We know about TB bacilli. That's a TB bacillus. Whenever the TB bacillus is in the body, so there are various population of this TB bacilli. Some of the TB bacilli, they don't, or they multiply very slowly, like dormant bacilli, or they don't multiply at all. And there are certain bacilli which are in the cavities where pH is neutral, and this is actually the best environment for the TB bacillus for multiplication. So huge multiplication happens if there is cavity. Larger the cavity, again more number of organisms, because this gives as these are aerobic organisms, they require oxygen, they love oxygen, so whenever there is oxygen they multiply fast. There are bacilli which will be within the cells, that is intracellular bacilli, that is for example macrophages, where there will be acidic pH, there will be multiplication, but the multiplication will be slow. We know that in the granuloma there will be caseous necrosis, so in the caseum there will be intermittent multiplication of the bacilli. So all these different groups of TB bacilli which are there at different places. So the idea behind using more than one drug together is because you want to stop, or you want to kill the bacilli and stop their multiplication from all these different sites. So if we look at these four drugs like streptomycin, INH, rifampicin, which are bactericidal drug, and ethambutol, which is bacteriostatic drug, all these drugs, they act in the wherever there is a cavity, and usually these are thin walled cavity, and they again are very effective in this environment. But within the macrophage, again, parazenamide has an advantage there, so it can act on the bacilli which are intracellular and which multiply in acidic medium or acidic pH. Rifampicin is very effective. Other than this caseum, where there is intermittent multiplication, it can also act against other population of the bacilli as well. There are some new drugs which have come in. You might have heard about bedaquiline, and then there is another drug that is dilamanid, which is a first drug of its own class, that is nitroimidazoles. So that is a new class of drug, and this first drug is dilamanid. So these are again reserved drugs, not used very commonly. A patient has to go through a lot of again screening and process to get these drugs. But again, these are the drugs which may act against dormant bacilli, which as I said, may not multiply. These are hidden and dormant bacilli, they are not multiplying, and these are drugs which are said to be like may act against that dormant population of bacilli. So that is the main logic behind using a combination therapy. You want to use a combination which is best possible for the patient, which addresses or which actually kills the bacilli from all these different environments, whether the pH is low or pH is high, or if it is a neutral pH. Now, why this drug resistance happen, or how the emergence of drug resistant mutant happens? First of all, these mutations happens in chromosome. These are chromosomal mutations, and these are unlinked mutations, which means that genes may be different, or genes these mutant genes may be on different chromosomes, or even if they are on the same chromosome, they are so apart from each other that that they are often segregated by recombinations. So it's low and it's a predictable but variable frequencies of mutations for the drugs. Emergence of spontaneous resistance to two drugs, it is highly improbable, which means that a person developing resistance to like both the drugs or more than one drug of its own or naturally occurring mutations, it is highly improbable. Usually it is a man-made phenomenon. We will come back to that point. Then appropriate drug combinations, they prevent emergence of drug resistance, and also the doses and everything has to be appropriate. So this is just to give an example that usually cavities you will be seeing in HIV negative or immunocompetent person, because again formation of cavity is nothing but it indicates that there is an immunity which is intact. It is a response to the immune system. So if there is a cavity, usually we see cavity in the upper zones of the X-rays or upper lobes we usually see, and the amount of bacilli in the cavity can range anywhere from 10⁻⁸ or 10⁻⁶ to 10⁻⁴, which again depends on the size of the cavity. The larger the cavity, again you'll have larger number of bacilli. Again, there are more chances of getting positivity over smear. The drug resistant mutations, if you see the naturally occurring again mutations and the comparison with the susceptible organisms, if it is rifampicin alone, it is 1:10⁸, and isoniazid again 1:10⁶, that is one sensitive organism, one resistant mutation, as against 10⁶ susceptible organisms. Streptomycin is this, ethambutol is 1:10⁵. But if you see here, rifampicin plus INH, which in our definition it is an MDR-TB, and if this has to happen, it is like 1:10⁻⁴, which is highly unpredictable, and you don't suspect that this has to happen naturally. So that I think we should remember. So again, it is utmost important to give this combination combination chemotherapy or combined chemotherapy for TB. This is all organisms or the drugs which are sensitive, or the organisms which are sensitive to all drugs or sensitive organisms. And ethambutol resistance, in the center you are seeing rifampicin resistance here, and this means it has resistance to ethambutol, rifampicin and INH as well. Now the most important drug we again are concerned about here is rifampicin. If there is resistance to rifampicin, in programmatic settings we take it as MDR, because there is again increasingly high background INH resistance. So what we suspect is if there is resistance to rifampicin itself, we can again programmatically say that it is MDR-TB. But of course, as definition goes, it is resistance to MDR and NH and rifampicin both. So what are the causes of these drug resistance? It is basically a man-made phenomenon, as I mentioned before. Usually it happens because of the poor treatment. Again, poor treatment includes all the things that poor prescription by the practitioner, poor intake by the client, and other reasons as well. Then poor drugs which are being used for treatment, poor combinations or false combinations which are being used. Then poor adherence to treatment, which is again from the patient's part if the patient is not taking treatment well. Inadequate treatment leads to again dominant drug resistant strains. If treatment is not adequate for whatever reason, so the sensitive bacilli will go down, number of sensitive bacilli will go down, and we'll have more and more dominant drug resistant mutant strains which are not again which do not respond to the regular treatment. Then the reasons again for drug resistance at molecular basis, it is creation of lipid rich cell wall. So around the TB bacilli there will be a creation of lipid rich cell wall, and then production of enzyme that degrades these drugs, and which results in again drugs which are not effective against those bacilli. And these are random genetic mutations. Genetic mutations leads to again ineffective drugs which we use generally as a first line. So inappropriate treatment protocols which are not following to the standard national treatment guidelines. You might have heard about the document which says about the standards of TB therapy in India. So where the 7th standard is regarding the treatment. So it clearly mentions that if a person or if anyone wants to treat TB in India, what are the protocols or what are the national treatment guidelines which have to be followed. Then if the duration of the treatment is inadequate, or even the combination you don't give properly, so that is again one thing which is considered to be like inappropriate treatment. Then we have seen, and all these things we will see few examples in next few slides, that these are not like unreal things. These are real life scenarios where you might have seen that so many people or practitioners, they treat TB, but most of them, they don't treat TB well. Either the combinations are problematic, or either the duration, or again there are other multiple reasons which lead to drug resistance. So this is one of the example. One study was done in Mumbai in long back in 1991, where 79 allopaths, again this is for the treatment of TB prescriptions practice in Mumbai. What they did basically is they saw how practitioners are writing anti-TB prescriptions. So you will appreciate this example that what I was saying before, that treatment was not given properly. These are some examples of that. 79 allopath and 64 non-allopath doctors in Mumbai. 31 refused to participate in this study, and all used essential NTT except 2. So 100 doctors prescribed 80 different regimens, and most regimens were inappropriate and costly. Most doctors used more drugs, and no doctor used intermittent regimen. And this study, which is again was done after 2 decades, again in the same group or this or same area, or practitioners from similar area. So this was again the title, as it says, tuberculosis management by private practitioners in Mumbai. Has anything changed in these 2 decades? It was done in 2010. The earlier was in 1991. So the participating practitioners have never been approached by the local TB program. Only 6 out of 106 respondents wrote a prescription which is a correct regimen. So this is what I was trying to say, that this is reality. This is not something so which is just our assumption. So it clearly says that out of 106 doctors prescribed 63 different drug regimen for treatment of TB, and there was tendency to overtreat with more drugs for longer duration. Only 3 of 106 responders could write an appropriate prescription for treatment of multi-drug resistance TB. Fortunately, unfortunately, it is available in everywhere in the country, and anyone can prescribe, anyone can write, but getting down to those proper prescriptions, it is so very important. And with this, we can clearly see that it is not happening as per the guidelines. So it is not only the case with one state. If you look at this study, which was done in Lucknow in the year 2002 by R. Prasad et al., that 449 doctors prescriptions were analyzed, and 33 different regimens were prescribed by almost 450 doctors. 62% doctors took weight, and only 50% advised sputum smear for AFV, which is so very important as far as spread of the TB is concerned. Then 45% of the doctors did not practice current NTP or National TB program, WHO recommended regimen. 75% of the doctor made prescription errors, and 70% almost doctors used FDC of 2 to 4 drugs. So this thing will be seen consistently. Like this study in rural India and rural and urban areas of Maharashtra, this is again to see the in private clinics what is happening. First source of help for 86% was private practitioners. So why this is being highlighted now in this presentation is again because we have such a huge national TB control program, but still 86% of the patients go to the private practitioners first. The diagnostic algorithm was inadequate. 15%, of course, it was done in 1998. 15% did not consider sputum examination to be necessary, and 79 different treatment regimen were prescribed by 105 reporting private practitioners. Again, 67% of the patients diagnosed in private clinics remained with private sector, and rest shifted to the public sector within 6 months of treatment. And treatment adherence rate among patients in private clinic was 59%. There was discrepancies between the reported management practices of private practitioners and what their patients actually followed. So this is again consistently, if you see study after study, it has been clearly and consistently said and documented that there is something big which is wrong, which is happening around us. So even though we are looking at this ART and TB first line, but we know that this is real life scenario around us, that TB can be treated by any, and we have seen in one of the studies like allopathy and non-allopathy doctors also they write TB prescriptions, which is not appropriate. So just see this example, and this is again very common mistake made by many of the practitioners. And now this patient was given as a first line anti-TB drugs, capsule rifampicin for 450 milligram empty stomach, INH 300 milligram after breakfast, pyrazinamide 500 milligram 3 times a day, and ethambutol 400 milligrams twice a day, and for 2 months, and then patient was called back for review. Do you see any problem in this prescription? So I'm just waiting for some responses if there are any. So it has been underlined that there is some problem with this prescription. So pyrazinamide has been prescribed like 500 milligram 3 times a day, and ethambutol has been prescribed 400 milligrams twice daily. That is, these are divided doses. We just saw in the previous slide that all these drugs have to be taken at the same time, and this combination is so very important. If you divide this regimen, what will happen? If you divide the regimen over a period of time during the day also, what will happen is this. So if you give, for example, pyrazinamide 1500 milligram once a day, so that is actually the ideal the drug dose, and the way it should be given. So the peak concentration reaches, and then it remains, which is above minimum inhibitory concentration for the bacillus or to kill that bacilli. So but if you reduce the dose like 500 3 times a day, what will happen is this. So this is always below minimum inhibitory concentration, which will not inhibit the bacilli, and what will happen is that though there is a drug, in presence of drug, the bacilli will multiply, the bacilli will be there, and this will not be effective for management of TB bacilli, and slowly resistance will develop to that particular drug. So because of this reason, these drugs are given at the same time, and they are not distributed over a period of time. So prescription errors are similar to this. So fortunately now we have in ART centers, the way we are giving TB treatment is through this fixed dose combination or combination chemotherapy. So that is actually not allowing patients to again distribute drugs over a period of time. But if you ask them, they might be taking like half tablet in the morning and half in the evening, or one tablet in the morning, one tablet in the evening. And again, the same thing will happen if they keep on doing like that. So these have to be taken at the same time. They can take like 5-minute break or whatever, but it cannot be like morning, afternoon, and evening, one tablet each. This will again create MDR-TB cases in your centers. So just to summarize how the development of drug resistance will be, there will be colonies of Mycobacterium tuberculosis, natural mutation will happen, drug resistant mutation can again selection of drug resistant strain by inadequate treatment, and that will create the secondary drug resistance TB. As I said, we have seen that there is such a less chance of having naturally occurring drug resistance mutation, but secondary drug resistance mutation or MDR-TB is the main factor is again the secondary MDR. But if this type of TB gets transmitted to another person, the another person will get MDR-TB from the beginning, that is primary drug resistant TB. And further transmission will happen with more primary drug resistance TB or more MDR-TB. So that is the main problem, that if we are creating MDR-TB in one patient, that does not affect only that patient, but also the spread of MDR-TB from that patient will be MDR only, and the next person who is getting the infection is again not will not be able to treat that person with the first line anti-TB drugs. Now there are some specific problems as far as PLHIV are concerned. So as all of us are dealing with HIV positive people and we are seeing TB in them, so all the more actually the problem of MDR-TB itself is big, but when it gets combined with HIV, it again becomes worse. First of all, there is a diagnosis delay in the patients who are HIV positive for TB, because again because of all those reasons of low immunity, you will not get positivity, and sometimes patients there are the tools for diagnosis of TB. So overall, if you see, there is a delay in diagnosis of TB in HIV positive patients because it is not that easy also. Then mycobacterial load with drug resistant mutants is likely to be higher in undiagnosed and untreated patients. Again, because of the same reasons, that X-ray might be normal, patient is not producing sputum, you are not able to test this sputum for CBNAAT or whatever. So it is difficult to diagnose, and the delay will cause increased number of bacillary load in their body, and also which will also increase the drug resistant mutations. Then again HIV positives, they will or many of them you might have seen, they will be having diarrheal diseases, or the intestine will be affected. So there will be malabsorption of INH, rifampicin, parazenamide, which make the treatment again ineffective. So acquired MDR-TB is more likely in immunocompromised. Again, hospital acquired transmission, because HIV positive with lower immune system, where the diagnosis of HIV and also if the TB is delayed, they'll have multiple admissions, or repeatedly they'll keep coming to the health facilities, and because of that there is a high possibility of having nosocomial or hospital acquired infections. So there are certain examples, if we can see, like plasma concentration of rifampicin. Now this is the study done in TRC, that is TB Research Center, and Government Hospital of Thoracic Medicine, Tamram, Chennai, and it was published in the year 2004 in Antimicrobial Agents and Chemotherapy. Three populations, like patients who have TB, patients who have HIV and diarrheal diseases, and patients who have HIV-TB co-infection. They saw the plasma concentration of rifampicin. So this has been again in microgram per liter, and after hours of giving rifampicin, they saw the plasma concentration, how much rifampicin each is reaching the plasma or the blood. So what they observed, first hour, you can clearly see the difference. This is the patient who has only TB, and this is the HIV-TB patient. So, and also HIV-TB patients with diarrhea. So patients who are in this category, the plasma concentration, even after like 3 hours or so, it is not increasing enough. So there is some malabsorption happening here. So even though you are giving TB treatment to a HIV positive, it is not reaching to the highest plasma concentration as it will happen in TB patients. So that is the one of the reasons which is actually associated with the HIV status of this client. That is why we always say that as soon as you diagnose HIV, start the patients on ART. ART plays such a crucial role. So it is not only again to treat HIV, but also to protect the PLHIV from the other diseases, including TB, because that prevention itself is again the most important thing. The mean percentage dose of those drugs excreted in urine. Now, in this study, which was again done in TRC Chennai, TRC and GSTM Tambaram Hospital, Chennai, and it was published in Clinical Infectious Disease Journal in 2004, where they saw the mean percentage dose of drug which is excreted in urine in patients with AIDS. Again, like previous, they had three population: patients who had TB, the patients who had patients who are HIV positive with diarrheal diseases, and patients who have HIV-TB co-infection. So here also you can clearly see that as compared to the patients who have TB, especially rifampicin and INH, the person who have diarrheal diseases and the person who are HIV positive and who have HIV-TB co-infection, the urine excretion of these drugs is much lesser, which again indicates that there is a malabsorption for this anti-TB drugs in the patients who are HIV positive, especially when they have diarrheal diseases or especially when they have HIV-TB co-infection. So let's see some of the definitions which we use. So a patient is confirmed to have drug-resistant TB only when the drugs are from only when the results are from RNTCP quality assured culture and DST, that is drug susceptibility testing laboratory, and by an RNTCP endorsed testing method. This is so very important to understand and remember. It is not a clinical diagnosis. Most of us are used to in making clinical diagnosis, but as far as MDR-TB is concerned, it is a lab based diagnosis and not from any lab. It should be RNTCP quality assured certified lab. So some terms which we should be familiar with, like mono resistance TB, as name suggests, or it is in short it is called MR-TB. So as name suggests, a TB patient whose biological specimen is resistant to one first line anti-TB drug only. For example, INH resistance, for example, ethambutol resistance. So that is called as mono resistance TB. If more than one drug is involved, it is called as polydrug resistance TB. So, but it is other than INH and rifampicin. If the person has resistance to, for example, only ethambutol and pyrazinamide, it will be called as polydrug resistance. INH and ethambutol, again polydrug resistance. But if it is combination is INH and rifampicin resistance, it will not be called as polydrug resistance. It will be called as MDR-TB. Though the definition wise it goes well with that, but as definition of polydrug resistance goes, so it is resistance to more than one first line anti-TB drug other than both INH and rifampicin together. Now, what is rifampicin resistance? As I mentioned before, a TB patient whose biological specimen is resistant to rifampicin, detected using phenotypic or genotypic method, with or without resistance to other anti-TB drugs. So it includes any resistance to rifampicin in the form of monoresistance, polyresistance, or MDR-TB, MDR or XDR. Like I said before, even though we said MDR as a definition, like resistance to at least INH and rifampicin, but only rifampicin resistance also might be taken as the resistance to INH and rifampicin both. TB patients whose biological specimen is resistance to rifampicin detected using phenotypic or genotypic method is rifampicin resistance. It is to be noted that rifampicin resistance is quite rare without isoniazid resistance. So majority of DST results with rifampicin resistance will also be INH resistance, that is MDR-TB. So this has been substantiated in the National Drug Resistance Survey, which we saw the slide before, that is 2014 to 16. Therefore, RNTCP has taken this programmatic decision that patients who have any rifampicin resistance, like in monotherapy or mono resistance or polyresistance or MDR, they should be managed as if they are having MDR-TB. Okay, so this is in line with also WHO guidelines for programmatic management of drug resistance TB. Now the definition of multiple drug resistance, that is MDR, multi-drug resistance TB or MDR-TB. Now TB patients whose biological specimen is resistant to both INH and rifampicin with or without resistance to other first-line anti-TB drugs is called as MDR-TB. Now these patients may have additional resistance to any or all fluoroquinolone or other second-line anti-injectable, but if minimum criteria is they should have resistance to INH and rifampicin to label those patients are MDR-TB. Now, not many years before, this new term came in, that is extensive drug resistance TB or XDR-TB. At some places it was called TDR also, but this is the standard term which is used, that is extensive drug resistance TB or XDR-TB. So the MDR, that means resistance to INH and rifampicin plus at least a fluoroquinolone, that is either Oflox, Leoflox or Moxiflox, and a second line injectable, that is anti-TB drug, that is kanamycin, amikacin and capreomycin. So this will form the definition of XDR. I'll repeat that the patient who has resistance to INH, at least INH and rifampicin plus one of the fluoroquinolone plus one of the injectable second line anti-TB drug, so which is kanamycin, amikacin and capreomycin. So these cases are referred to as XDR-TB in the program. Now, overall model of care in RNTCP programmatic management of drug resistance TB, you have a health facility which is called as PHI. Now, every ART center is considered to be a PHI by the TB program. Now, what we do is we follow the patients, we do the physical examination, culture and biochemical test whenever it is required. So, whenever we diagnose anyone who is CBNAAT, whose CBNAAT results are showing like microbiologically confirmed TB but rifampicin resistance, we have to send that patient to DR-TB center. Now DR-TB center can be at the district level or it can be again nodal DR-TB center. So DDR stands for District Drug Resistance TB Center and NDR is Nodal DR-TB Center. So the difference is again, this is they can initiate ART anti-TB drug treatment of drug resistance TB, but and also both the centers can initiate, but this is again a center where these centers can refer the cases in case there is any toxicity or any further management is required. So the tests which are used for diagnosis are CBNAAT, again which detects microorganism plus it detects resistance to rifampicin, LPA, that is line probe assays, or drug susceptibility testing, which we will discuss in detail later. So PHI has the case, they will refer to a DR-TB center which is at the district level. So DR-TB center will either hospitalize the patient for treatment initiation, and which is in again, or it can be done in complete ambulatory care also. So the patient is linked to either DR-TB center at the district level or the nodal DR-TB center, and simultaneously the results are confirmed by doing the other test. We'll see what are those other tests and how it is done. So this is the diagnostic algorithm which we use CBNAAT results in the ART center. So we use CBNAAT results. If MTB is not detected, we consider other differential diagnosis. If MTB is detected, but if rifampicin is sensitive, we give either 6 months treatment or we give either 8 months treatment depending on the previous history of the patient of TB treatment. If the patient was treated before for less than 1 month or patient was not treated before, then the patient is given the 6 months treatment, and if the patient was previously treated for TB or treated for more than 1 month at least, and then if you want to start TB treatment in that patient, you start with the 8 months treatment in which you have injection streptomycin for first again 2 months, and then 4 drugs for next 1 month, and then 3 drugs in the continuation phase. So total 8 months treatment. Now this we already know and we already practice, but MDR Mycobacterium TB detected and rifampicin resistance in our guideline we have seen till now that refer to the DR-TB center. So what are the guidelines for that? So we need to see if the patient is new TB patient or previously treated TB patient. That means the patient is was never treated before, or patient was treated before for more than 1 month, or if never treated, or the patient was treated for less than 1 month with anti-TB drugs. Then we refer to DR-TB center and what they do. And if the patient was new and it was not patient did not take anti-TB drugs in past, or if at all taken it was less than 1 month, then in DR we just refer to the DR-TB center and the previously treated TB case. So there is confirmatory CBNAAT which is done. If it is sensitive, again if the rifampicin is sensitive, then if the rifampicin is resistance, then the patient is referred to the DR-TB center. Sensitive, again the test with the LPA is done, that is first line LPA or liquid culture, and then treatment is started as per the DST or drug resistance TB center decision. So the way we treat this at the ERT center, whenever we see drug resistance, we just refer the patient to the DR-TB center. We'll talk about all these tests and how these are done in the next few slides. So presumptive case, that means the pediatric case, age group PLHIV living or vulnerable from the vulnerable groups, and these are all vulnerable groups or key groups or key populations. That is pediatric age group, people living with HIV, which we are directly related to. Then in extrapulmonary TB sites, smear negative or not available with X-ray suggestive of TB. So, or if the diagnosed TB patients, but they are not non-responders to treatment was started, but again follow-up sputum was positive, or patient is deteriorating, or patient is not responding to the treatment, then all the patients who are DR-TB contacts, previously treated TB case and HIV TB co-infection again, and new TB contacts, the CBNAAT is done, and we will see whether it is rifampicin sensitive or rifampicin resistance. If the patient is rifampicin sensitive, in our situation, we start the patient on 6 months treatment and or 8 months treatment based on the previous history. But whenever the facilities are available, these patients, especially when they were treated in past with TB, they need to be sent for first line LPA. What LPA does is, now LPA stands for again line probe assays. These are again a molecular level test which will detect the mutations in the TB bacterium DNA using again a coloring agent that highlights the gene mutation associated with the drug resistance. So these LPA, once it is done, it will give, now first line LPA is for INH. So you are seeing basically here, because here in CBNAAT you saw whether there was resistance to rifampicin or not, but here you are seeing whether there is resistance to INH or not, or sensitivity to INH or not. So INH can be sensitive or INH can be resistance. If there is INH resistance, then second line LPA is done, where more drugs, sensitivity to the other additional drugs is seen. That is like fluoroquinolone, that is second line and or injectable sensitive, or fluoroquinolone and or second line or injectable resistance. So based on this, the patient is diagnosed to be having MDR-TB or again polydrug resistance TB, and accordingly TB treatment is given. So in a summary, like after doing CBNAAT, a person diagnosed with DR-TB, we send the patient to the DR-TB center. They do again line probe assays. First they will do LPA1 for INH resistance. If INH is resistant, then again second line LPA is done, and based on that the diagnosis of whatever drug resistant is there, that is made. So if it is diagnosed to be MDR-TB, there is a specific protocol which is followed for the treatment, which we will do in the second part of the NDLS. But if it is like more than 2 drugs which are involved, or more than 2 drugs there is a resistance, then based on the resistance or culture sensitivity report, the treatment is again revised in that particular patient. So this is again a choice for testing. As the first choice, we use CBNAAT or line probe assays. Then we can use liquid culture isolation and LPA-DST, that is line probe assay drug susceptibility testing. Then liquid culture isolation and liquid DST, that is another option which is used as a diagnostic technology. So let's talk about these tests which I was talking about previously also, these molecular level tests and these other tests which are line probe assays or CBNAAT and all. First of all, we know that for diagnosis of TB, we historically we have been using this sputum microscopy. So, but you might have heard this multiple times that microscopy was not enough to diagnose TB, and X-ray also was not enough to make a diagnosis of TB. That is why we moved from sputum microscopy to CBNAAT, and yield of which is again double than the sputum microscopy. And then for diagnosis or reconfirmation, again we do CBNAAT, which tell us about the microorganism and also about rifampicin resistance. But if you want to know resistance to more drug than that, we use another test, which is line probe assays, which are again a molecular level test, and which diagnose the additional drug resistance. For example, INH again depends on first line or second line LPA. So these molecular level tests or nucleic acid amplification tests, they again provide accurate and rapid diagnosis of TB by detecting Mycobacterium TB and rifampicin resistance. And then the test can be performed on both respiratory and non-respiratory specimen. So CBNAAT gives results in just 2 hours. Line probe assay may take some time, like 72 hours. Again, if you compare CBNAAT with line probe assay, CBNAAT can be done by anyone in the periphery also, but for line probe you require more skilled people and it has to be done in central labs. So there are at least 2 tests which are available, like genotype MTB-DR test and Inolipa RIF-TB test, which is under line probe assay, which is available. So presently RNTCP is and under RNTCP its use is recommended for diagnosis of DR-TB in presumptive DR-TB patients and TB in children, EP-TB in key populations such as PLHIV. So but the clear thing is that we are not doing LPA for all those patients, even if they are HIV positive here in our center, but wherever the facility is available, and if there is these are the high risk patients or these are the priority patients or key populations for this MDR-TB. So in those cases, again line probe assay wherever possible it should be done. So this is just to show the CBNAAT, how it is done. There is a small cartridge here, there is a machine which is very small, size of your CPU, which can be kept anywhere, and of course there are some minimum requirements, but with minimum training this test can be done even in the periphery, and which is already being done. So it is very sensitive even to the other non-pulmonary specimens other than blood and urine and feces. All other specimen can be tested for CBNAAT, very specific again, good in extrapulmonary sample also, and it will give results within 2 hours. Line probe assays, as I said before, these are called actually line probe assays because they detect mutations in the TB bacterium's DNA using coloring agent that highlights the gene mutation associated with the drug resistance. So they can be DNA and RNA amplified hybridized onto nitrocellulose strip for detection of TB resistant mutations. It identified most common INH these are again mutations, INH A and CAT-G, and 92 to 99% sensitivity, and also rifampicin, that is RBOB, that is 96 to 100% sensitivity. These genes are directly from the clinical samples in 2 to 4 hours. Now these are again mutations. Those who are interested in remembering them, they can remember, but this is just a list of from each drug which mutations or which genes they get involved. So RPOB or for INH you have these 3 mutations again, these genes which get involved, and paracetamide, and for ethambutol, for streptomycin, and for fluoroquinolones. Like in LPA, we have seen that this is again a type of genotype MTBR plus procedure. like again, I already said a couple of times, it is because of the coloring agent that highlights the gene mutations. So you have a specimen here, DNA is extracted, and again this amplification of the DNA is done, that is through polymerase chain reaction, and then hybridization and color reaction is made. You can see that on this strip where it will show all these mutations which we just saw in the previous slide, and based on that it is decided that which genes are involved. So there are some other tests which are used again to see the susceptibility of the drugs. Till now we saw that drugs or the tests which identify the resistance, but for drug susceptibility testing, the ideal is again culture. Though highly sensitive, though culture in highly sensitive and specific method for diagnosis, it sometimes requires a long time. So you might have seen culture reports. The solid medium usually we use is LJ medium, Lowenstein-Jensen medium, which takes almost like 6 weeks or 8 weeks sometimes to get the results. So early detection is cannot be done through the standard culture TB culture by using the solid medium. So, but again, it has its own importance in the follow-up patients on drug resistance TB and can help in detect the early recurrence in both drug sensitive and drug resistance. So, growth-based phenotypic culture methods that include automated liquid culture systems like BACTEC, MJIT 960 or BACTEC alert or BACT alert. These can be used for again to see the drug susceptibility testing. So this is an example of that solid culture. This is LJ medium. You can see this typical slope and colonies of TB bacilli here. Though it is ideal, but it takes long time. So not very helpful for initiation of treatment of MDR. This is MJIT or Mycobacteria growth indicator tube. So this system uses liquid culture to test if the bacteria will flow or will grow in the presence of various TB drugs. Obviously, if it grows, then the TB bacterium is resistant to the drug for which it is being tested. But again, it will take some time. It will take several days. Though it takes some days to give the diagnosis or to give the susceptibility of the drugs, but it is faster than the solid media or LJ medium or solid culture testing. So as similar to LPA, again this test cannot be done in periphery. So Mycobacteria growth indicator tube or MGIT, this has to be done in centralized lab at some places. It cannot be done in the periphery. There are some other tests which you might have heard like IGRA or interferon gamma release assays or antibody based tests or serological tests. Now first of all, serological tests are banned in India. These are no longer being recommended or no longer being used for diagnosis of TB because of the main reason that they do not differentiate between TB infection and active TB disease. You might have heard tests like quantiferon or TB gold or immunocheck or immunocheck TB platinum and all that, or other serological tests like antibody based tests. But they should not be done actually in the country like India where the prevalence is so high, and you will get even if you get the positive results, you will not be able to take any decisions based on those. So highly discouraged, not being used. So IGRA is one of them, that is interferon gamma release assays. So that doesn't have any role here. I just mentioned because just to complete the list of testing. So this is the integrated drug resistant TB algorithm. Now this you can find on tbcindia.org website, that is TB RNTCP website. There is a whole guideline for PMDT, that is PMDT treatment guidelines for programmatic management of drug resistant TB in India. That was actually released in 2017. There can be some local variations or local adaptations. So even though there is a national guideline based on the availability of test within the vicinity of wherever you are, so the local RNTCP actually decides the best possible way to do it. Because, for example, if I say that okay, LPA has to be done for everyone, then you will not have facility to do the LPA. So for that reason, the way it is being done in your own locality, that has to be consulted with the local DTC, and accordingly it has to be followed. So few of these things we have already seen previously, and as I said, for more again detailed description, you can also refer to the PMDT guidelines of 2017. So CBNAAT is done for all presumptive TB cases and all diagnosed TB patients who are not responders to the TB treatment. So CBNAAT can be done in those, and you can see rifampicin resistance or rifampicin resistance or rifampicin sensitivity. If rifampicin is sensitive, we give the patient first line anti-TB drugs, and it is continued for the whole duration of the treatment. But if the patient was earlier treated, or the patient has HIV co-infection, which in our case is likely to have, or in our case all the patients are PLHA, and wherever the facility is available, well, where the test is available, first line LPA is to be done to see whether there is resistance to INH, or there is a or whether INH is sensitive. And if INH is sensitive, again first line is to be continued. Again, I'll just repeat that if the lab is not adequate enough to take the enough sample, because ART centers, they have thousands of patients and hundreds will be having TB. Now everyone who is having HIV TB co-infection, you cannot just send them to for first line LPA. So we are just doing CBNAAT, and we are giving 6 months or 8 months treatment to those patients. So but if the facility is available, you can get it done. So if you diagnose INH resistance, then INH mono, because here you had seen that rifampicin is sensitive, only mono resistance is there, or the patient might have the resistance to INH plus other anti-TB drugs other than rifampicin. So these patients will not be said MDR, but they can be called polydrug resistance TB. So according to the test result, the regimen is decided, because through MJET or the other methodologies, we have seen that drug susceptibility testing is done, and based on the result, whichever drug is sensitive, the person is put on those treatment. Now, on the other hand, if the patient is having rifampicin resistance from the beginning, again the second line LPA is done, where the other drugs are also seen, whether fluoroquinolone or injectable anti-TB drug, the second line injectable anti-TB drugs are sensitive or not. Then these days MDR-TB treatment has been shortened. It is not like 2 years or 24 months as before. It is given for 9 to 11 months, that is shorter MDR-TB regimen. But in some cases, like for example pregnant women or extrapulmonary TB, it is still given for 24 hours. But other than that, all patients receive a shorter MDR-TB regimen, that is for 9 to 11 months. We will discuss this more in the part 2, where we will be talking about the treatment of MDR-TB as such. Then so the same, if the in the second line LPA, if we see the fluoroquinolone and second line injectables are sensitive, then we will continue the same regimen and complete the regimen. So as I said, we will discuss this later in the next part. And if there is fluoroquinolone or second line injectable resistance, again the newer drugs are tried, that which we saw before, that bedaquiline or dilamanid and other drugs. So as far as treatment is concerned, as I said, we'll focus on the second part, but I think on the first part we can focus in this presentation. And as I said, there are like detailed guidelines of PMDT on the RNTCP website. You can again go back and check that. I think that is my last slide regarding diagnosis. I know for the people who are listening this for the first time, it may look like much, but it is actually not. So we need to be aware of like basic testing and treatment protocols, what is happening under RNTCP for the TB patients, for the very reason that all these patients are coming back to us. So these are the key points. We in this presentation we saw the magnitude of drug resistance TB, magnitude in India. We saw that report of national survey for drug resistance, causes of drug resistance, enhanced drug resistance TB in PLHA. We just saw that why in PLHA this problem is much more again than in non-PLHIV HIV patients. Then we saw definitions of mono, poly, and drug resistance and XDR-TB. We also saw the diagnostic algorithm of drug resistance TB. Then we discussed few tests, that is LPA, CBNAAT, MJIT, and a brief about the interferon IGRA also. Then we talked about the drug susceptibility testing which is being done, so based on which the treatment protocols is decided for the patients who are having drug resistance TB. I highly acknowledge the support from Dr. Rajshekharan for this presentation. Actually, the slides were made by him, so I'm just presenting this for this NDLS. But we thank Sir for his constant support. Today, actually, the TRG is happening, so I think he's not able to participate. But in absentia, my heartfelt thanks to Dr. Rajshekharan, who is again a teacher, guide, and everything for all of us. So that's my last slide. So I thank everyone. We have just made it on time. If there are any questions on or comments, we still can have in a couple of minutes. So thank you.
Thank you, sir. Thanks to all the participants. The details about the next session, which is part 2, will be informed to everyone soon. I request all the participants to kindly enter the e-poll, which will be displayed on the screen shortly. Thank you.